We are going to go ahead and get started for this evening. This is Kelly Atchison, a member of the NFED staff, and I'm going to serve as your moderator tonight. But first, I want to review a few housekeeping items. First off is Q&A. I did receive a few questions prior to this evening's webinar, and our speaker has those questions. They will be addressed during our time on the webinar. And we will also have a time for a short question answer session at the end of the presentation. So if you are viewing the webinar on your computer, you can submit your questions using the chat function or the Q&A function on your screen. After the webinar, you can submit your questions to me by email. So grab your notebook and a pen for some notes. I'm going to give you your first note to take. I'm going to give you my email address. It's kelley@nfed.org. You can also find my email address on our website. So any questions sent to my email we'll answer at a later date. Just wanted you all to know that. Secondly, we are recording this webinar. If you're not available to watch or listen to the entirety of the webinar this evening, you will get a link to the recording early next week and possibly even tomorrow if all of our technology is working. So without further ado, we're going to get started. So welcome to Conference from Your Couch. The NFED is happy to present 6 topics for families affected by ectodermal dysplasia. And tonight is our first webinar. We're going to hear from our speaker, Sarah Briggs, who's employed at one of the NFED's Dental Treatment Center, Ozark Prosthodontics. And Sarah is going to explain how to file your ectodermal dysplasia insurance claims like a pro. And I know she's worked a lot of time on this topic with her own patient, not only with her own patients, but with other families that have contacted their office and then me. Sarah joined Ozark Prosthodontics in 2017 after she graduated from the University of Arkansas with degrees in international relations, French, and European studies. And she's always been interested in healthcare policies and practices, which is initially what sparked her interest in Ozark Prosthodontics. She's currently serves as a medical insurance advocate and will be starting law school in the fall, where she hopes to become a specialist in health insurance law and medical malpractice. So now's the time where I stop talking and I turn everything over to Sarah, and she's going to talk to us just a little bit more about our topic. So go ahead and share your screen, Sarah.
Okay. Let's see if I can do this right. Let me see. Can you see it okay?
I can. Everybody else?
All right. If you can't see it, yell, okay? Thank you for that sweet introduction. Like she said, I do use medical insurance with our patients pretty much every day. We thankfully got started in this process 8 years prior to me, so I've been doing it for a little over 3 years, but thankfully work for an office that understands the trends and everything that seems to be changing with health insurance. So today I'm going to kind of talk about how to successfully use your medical insurance for treatment, say in a dentist's office. A lot of treatment can be covered in other offices, say if you need like hearing aids or glasses, stuff like that. This can kind of be applied there, just kind of taken into their specific diagnostic code. So now we're going to focus straight on your mouth. Once you get your insurance plan, what you're going to want to first do is understand what you just bought. You just got a new car off the lot. What all tricks does it have? So we want to get some documentation from our insurance broker or whoever got it for us. Maybe you got it through your work or through your spouse, something like that. There's going to be a department that can pass you information on your plan. So we're going to want to get what's called a summary of plan benefits. This is a big document. It's usually a minimum of 100 pages, and it kind of says exactly what's covered, when, where, and how, and what is not covered. That's good information to have just in case you do have kind of like a freak accident where you sprain a pinky toe and you just need to know if spraining pinky toes is covered. So good information to have for all forms of treatment. Once we have that in front of us, we're going to want to do what's called a benefits verification phone call. So we do this pretty much for our patients at the beginning. We just want to know what we're getting our hands into and wanting to know if we can actually help them. knowing your benefits, if they're available, is kind of just the beginning step to leveraging your health insurance. So I'm going to show you a terrible example. My handwriting is not the best, but this is kind of the documentation that I use on a daily basis when I do a benefits verification phone call. Oops, no, it's not. There you go. Okay, so here's a phone call, and what we want to retain is the day that we made it. So we made it last week. We talked to a customer service representative named Judy, and my reference number is listed above. What I wanted to accomplish on this benefits verification call are my CPT codes covered? So these are 3 CPT codes that are on the dental toolkit that is on the InFed website. If you don't know where that is, you definitely want to be familiar with it because we use this pretty much every day. So I want to know if I can have maxillary bone grafting, mandibular bone grafting, and if I can have some implants. So I say, hey, Judy, I have these 3 codes and I want to see if they're valid or billable. And she'll say, yes, Sarah, they're all valid, they're all billable. And I'll say, great. So now I want to know, are there any limits or restrictions to these codes? Is there one code that you can only bill once? Is there one code that you can only bill twice? Is there anything that I need to know billing wise? She'll say no, none on the maxillary. On the mandibular, you can only do 2 units a day. And then on the implants, there's no restrictions. Great, awesome. Next, I want to know, do I need to pre-auth these codes? So while I have these benefits, if I don't pre-auth them, then they can deny them still. So we want to get all the information we do before, all the information we need before we go forward with a claim. So all of my codes need pre-authorization. Once I'm on the phone with Judy, Judy can usually help me get my pre-authorization started. So she'll say, hey, what are your diagnostic codes? And I'll give her my diagnostic codes, and then I'll give her my CPT codes. And then she'll say, okay, reference number is XYZ, this is your case number, and you can fax your clinicals to this number. Once we get that started, that's kind of the beginning phases of starting to know if your treatment is going to be covered in that office. I want to jump back to this kind of weird layout, sorry about that, but there's a little bit of talking that I want to do on in-network versus out-of-network provider. I know it's kind of confusing because we go to a doctor usually and they maybe just take our copay. So I go get my flu shot, they check out my tonsils, and all I pay is my $30 copay. Why do I go to a dentist and pay $10,000 in front? Well, it's a little bit different. Typically, dentists are going to be out of network. I don't really know a lot of dentists around me that are in network with health insurances, so I'm assuming it's going to kind of be the same for you guys. So majority of them are going to be out of network providers, which means that either they're leveraging your out-of-network benefits, or we're going to go forward with trying to get a gap exception so that that provider can be treated as an in-network provider and leverage your in-network benefits. When we're on the phone call with Judy, we can also initiate a gap exception. A gap exception is a geographic exception. It kind of says, hey, Dr. John is the only doctor within 200 miles of my family. I know he's out of network, but can you please allow him to act as an in-network provider just for the course of my treatment? Once you get an approval on that, then it'll help lessen the out-of-pocket costs for you. Unfortunately, since they're not a true in-network provider, they can still balance bill you for something that's not covered, but usually they're paying at a higher rate, so it's a lot less for you, which is nice. So here is kind of a page from the benefits section in our summary of plan benefits. This is under actually exclusions, so it's kind of a double negative, but usually we're going to find our reconstructive surgery portions under exclusions or something maybe under cosmetic, anything like that. That's where we're going to find the information that we want. And so the first line says they're not covered except for congenital abnormality. So that's the line that we want to see, and that's where we know that we have benefits that we can go forward and leverage. Once we have all this information gathered, a lot of pre-work, then we can go forward with our pre-authorization. So this information is available on the toolkit as well. Like I said, we use the toolkit all the time, so if you haven't checked it out, I would definitely look at it. And this is kind of the big packet that we send and submit on a daily basis for our patients. So head and neck evaluations, this information is going to come straight from your dentist. So if you're not working closely with your dentist, I would recommend forming a relationship with them because I can't diagnose you and neither can yourself, but your dentist can give this information and sign off on it. So insurance is looking for clinical information from them. So establishing a relationship between them is going to be crucial to getting this stuff approved. A head and neck evaluation is pretty straightforward. It's just your head and neck. That's kind of where dentists specialize, is head and neck. So you might have noticed it when you go in for like a new patient appointment. They're kind of just feeling around on your neck or your cheek or anywhere weird that isn't related to your teeth. And they're kind of just doing a screening in their head, like, oh, Sarah doesn't have that today. They're just mentally checking it off. And a head and neck evaluation is kind of the documentation of that process. So they're doing it already. Should be super easy to document and to get a hold of. They're pretty much trained on it. That's what they spend all their years on. The next thing is a clinical note. And this note isn't like a typical note, like a one that you would see in a clinic. It has to be written in a SOAP format. The SOAP stands for Subjective, Objective, Assessment, and Plan. So once you get used to writing in that form, clinicians, then it's very easy to continue that. SOAP format is kind of just the medical standard of a clinical note. So it's kind of easy once you get started. It's a little weird at first, but it kind of hits all the ticks that you were going to put in there anyway, just kind of lays it out differently. If a CT is made, then a CT interpretation will need to be done. You can interpret your own CT, or you can send it off to a radiologist to have them interpret. I would recommend kind of specifying, hey, we want you to look exactly at this area, lower left mandible, something like that, so that they're extra thorough in that area. It is nice to have another professional looking at this case just to help get it approved. This is one of the things where you can have enough cooks. There's not too many cooks in this kitchen. Any doctor that's willing to sign on to this treatment is going to be an asset to the team's goal of winning. After that, we have our letter of medical necessity. This is kind of, I like to think of it as a painting. It kind of paints a picture of where this patient has been, why where they currently are is not working, why it's not enough for them, and what will happen if you don't intervene. So I'm missing, say, 6 teeth on my posterior region, so in the back, and I can't chew any food. Why is this going to be an issue? Because in 5 years, I'm not going to be able to eat the right food. I'm going to have gastrointestinal issues, any sort of thing that can come from not having that back area ability to chew replaced. And then also I attach the benefit verification phone call, and I also attach any additional documentation I have. So if I have a page from the summary of plan benefits that says that this is covered, if I have another doctor who has diagnosed me with something, if I've been to a geneticist who has any sort of genetic panel or any sort of documentation that they're willing to give to me, I put everything in there. This again is one of the things, you can't have too many cooks in this kitchen. You basically want a foolproof thing that says you basically can't deny me, and that's unfortunately how it has to be. Also in this, for our fully funded patients, we attach a page. We actually attach all 3 pages from an act that we leverage. So if you have a fully funded plan and you live in Arkansas, for example, we leverage an act called the Arkansas Act 373. And this act allows patients with fully funded plans to leverage their health insurance to get treatment for anything related to a congenital anomaly. So it's a really nice asset to have for patients in Arkansas. And I know that not every state has this, but your state might have it. So look at that legislation. And then also, if you haven't looked into the Ensuring Lasting Smiles Act, then I would thoroughly recommend looking into that as well. This is just trying to get this type of legislation out there and available for everyone to use and utilize. If we have gone this far and you get a denial, if they just say, hey, there are absolutely no benefits in this plan, and your plan is purchased through, or you obtain your plan through your employer, I would recommend reaching out to someone high up in your company that you have access to and just kind of pleading your case and saying, hey, Jim, I have ectodermal dysplasia. I need this treatment now. I can't function anymore like this. I absolutely need this treatment. It's medically necessary. I have 15,000 doctors signing off on my treatment. Will you consider putting this in the summary plan benefits as a covered benefit? There are great people out there that will, advocate for you and put this information in there. If you don't happen to find one of those people, then you can always consider finding your insurance through something else or someone else. You can get it through your spouse, or during an open enrollment, you can purchase your own plan. Find any means that you can to get this covered, because there are benefits out there that you deserve to utilize and not have to pay out of pocket. Okay. I know I'm going through this kind of fast, so make sure you write down all of your questions. I will answer them as best as I can. I'm going to hop over to the medical lingo. So in dental world, I'm sure you all have heard of like the tooth numbers and just crazy regions in your mouth that no one knows. That's kind of dental lingo. So 2, 3, 4, 5, 6, all your tooth numbers. When you switch to medical filing, you want to translate that into medical lingo. So instead of submitting a claim to your medical insurance saying, hey, I placed an implant at number 2, you would say, I placed, or a bone stabilizer was placed at the area, I think it's the area below the right zygomatic arch, or whatever that might be. Don't quote me on that, but there's anatomical regions for each tooth number. And dentists did learn this back in school. They might have to do some brain searching, but it is definitely something that is covered. And if you kind of forget them, you can Google them as well. Google's great for this. And just plug and play where you see tooth number X, Y, Z, put what actual geographic landmark it is. So here we have the ICD-10 and CPT codes that we use. Again, this is on the dental toolkit if you want to look at that. These are not, the diagnostic codes are not something that every patient's gonna have. I will say with an ectodermal patient, I'm gonna use probably at least the first 3 codes. Those are pretty straightforward, pretty much always gonna be an ectodermal case. But as far as the codes below it, you might not have that, or you might have more than that, and that is totally fine. Just find the appropriate diagnostic code that goes with your case. Don't just copy and paste these, because you might not have these. So your dental professional will be able to tell you, hey, you do have atrophy, or no, you don't have atrophy. You might have too much keratinized gingiva, so you might need some crown lengthening, something like that. There's a specific code for everything that you might need done. And then on to the CPT codes. These, again, are just some that we use. Obviously, there are more. There's hundreds and thousands of CPT codes out there available. Just, kind of get the treatment plan and go over it with your dentist to figure out what's going on. And there's going to be a medical equivalent of what is happening. So your 41899 is typically used for your extractions. The 21210 is maxillary bone grafting. And this code does mean that you did harvest. So if you didn't harvest or take some autogenous bone from the arch, then you'll have to put a modifier that lessens the fee that's given, but no big deal. 21215 is the same thing. It's mandibular bone grafting, and it is also implied that you harvested from the mandibular arch. So keep that in mind, clinicians, when you're doing that. Your 21085 is your surgical stent. We typically use those to place implants. And then down to the 21248, that is partial reconstruction of the jaw. So if it's 1 to 3 implants that you're placing, then that's partial reconstruction. If it's 4 to 6, then it's 21249, and that's a complete reconstruction. Your 15275, that's a soft tissue graft. That is allograft. That is not donor material. So if you're doing a donor tissue graft, then there's a specific code for that as well. And then 21089 is your maxillofacial prosthesis. So when it comes to crowns, bridges, temporary arches, dentures, whatever you're getting, it is a prosthesis. So this is the code that we would use no matter what the final product is. So if it's a crown or a denture or something like that, it's going to be your 21089. And each diagnostic code dictates which CPT code you're going to use. So if you have atrophy, then you're going to need bone grafting and at least one bone stabilizer, or at least one implant to stabilize your bone. So if you need Crown lengthening, you're going to need a diagnostic code that says, you know, too much gingiva or something that says you need this crown lengthening. If you need pretty much anything in the medical world, it's going to have a diagnostic code tied to it. That's a good way to get a denial if you don't have any diagnostic information that says, no, you need this, because otherwise it's just seen as an elective procedure. So these are just a few claim filing tips that I have come about while looking. Obviously, make sure everything is in one form of ICD-10 data. So it can be your ICD-9 or your ICD-10, but ICD-10 is kind of the standard right now. So I would translate all of your codes into the ICD-10 codes. These are on the dental toolkit. If you ever get confused and you lose the sheet, you want to know what it is, there's a standard few that we use on, I think it's page 3 of the dental toolkit, and you can see that they're all in the ICD-10 codes. So you want to type the information on a paper claim. You don't want to handwrite it in. It's better to have it typed and legible than illegible, and a lot of handwritten stuff is not going to be accepted from most insurances. And then we want to use the proper paper claims. So there are dental claims that you can use. You're not going to want to use one of those. Like I said, dental claims are going to be in dental lingo. They're going to have tooth numbers associated with them. But we want to use a CMS claim. We want to use the medical claim. And then I have a little example. This is the first half of a medical claim, like a CMS claim. This is where you have all of your member information, patient address, phone number, all of that good stuff. If you have any additional insurances, you would list those here. It kind of asks if it's related to employment, auto accident, other accident. So here they're trying to figure out, is it related to any other insurance that could be paying for it? You say no, it's not related to that. Here's the actual, this is that bottom half of the claim. So here are some common diagnostic codes up there. We have the craniofacial, the anodontia, and then we have the ectodermal code as well as an atrophy code. So it looks like this patient had some bone grafting done on the maxilla. And as you can see, they had 1 unit done. And then they had some implants also, and they had 4 units done. So they used the 21249, not the 21248. You can see they have the rendering providers in PI on the bottom line for both of those. You have your date of service. I don't know if you can see me moving my mouse, but you have your date of service on the left side. And then your place of service, 11 means the office. So I was at an office and got it done, and it was not an emergency surgery. And this bottom information, as well as the tax ID information, is information that your provider will have to give to you if you're self-filing. If you're a provider filling this out, you should know this. You have your tax ID, you have your facility location, your billing provider information and phone number, pretty much information that you should just be able to pick up and play with what you have available to you. And if you don't have that available to you, you can contact your doctor's office and ask them, say, hey, you know, we're trying to do this. And sorry, that just notified me. And this is the information I need. They'll typically be available and able to answer your questions. I did have a few questions passed to me, so I'll go ahead and pre-answer those if I hadn't answered those in the actual presentation. There was a question on how to communicate with your dentist office. And I, speaking from a dentist office that does file this, might be a little naive in answering this, but I think that there's no amount of communication that isn't the right amount. So if you feel like you need to contact them every day and say, hey, I know that this is new information to you, but if you're willing to work with me and get this information together and we can file it together, that would be great. I think the best approach to take to this, if you're coming from a area where your provider is not filing, it might be easier just to kind of partner with them and say, hey, I'm willing to help push some of the paperwork forward. A lot of it is going to be a lot of paperwork up at the front. And that would be really nice information for you to help with if you can. I don't know if you can. And then some other information, other questions that I had been passed were about the CPT codes. So again, I just want to reiterate, I'll go back to this slide. Oops. The CPT codes, these again are typical ones that we use. Like I said, there's probably a CPT code for getting your tooth extracted on a Tuesday. There's CPT codes for everything. I mean, I've seen one where you fell and slipped on a skateboard and hit your mouth on a pole. So there's really a CPT code for pretty much, or sorry, that's a diagnostic code, but there's a procedure code for pretty much everything as well. And again, the prosthetic code is going to be one that you're going to use for any type of prosthetic that you're going to get, whether it be a crown or a bridge or something fixed, a denture, anything that you're going to get. It's going to be a maxillofacial prosthesis because that's just what it is. And like I said, there are way many more diagnostic codes than are listed here. And if you have those, obviously your professional will tell you about that, and it can just go as more evidence in your case as you know your treatment kind of progresses, and you might need something else done. You might need some sinus lift or something like that. That's just diagnostic information that can be added to build your case. And so that was kind of a quick overview. And I understand if you have a lot of questions, so feel free to ask them now. I don't know if I can, let me see if I can. Let's see, I don't want to say your names.
You should be able to stop sharing your screen. I'll see if I can do it from my end. There. Let's see.
Oh, there it is. I got it.
Okay. We've got a lot of questions, and we're going to try to get to all of them in the remaining 30 minutes of our webinar this evening. If by chance we do not get your question answered, please send me an email, and we'll be sure to address that at a later time, and we'll address it directly to you. So one question is, can dental implants be covered by medical insurance, crowns, bone grafts, etc.? I think you've addressed that, but do you have any additional information maybe that you could share, Sarah?
I'm sorry, what was that?
The question is, can dental implants be covered by medical insurance?
Oh, yes, they absolutely can. One thing you're going to want to find out is if it is actually covered in your plan. There are some plans that directly exclude that. That is very true. But I would do the beginning phases that I said, call and see if they're covered benefit, call into your HR department and try to get your summary of plan benefits and see if that is an actual exclusion. A lot of times it'll be an exclusion, but there are like a double negative where it's an exclusion except for when it's to correct a congenital anomaly. So in that case, it would be covered.
Wonderful. So another question that we have is, let's see, let me try to summarize this. This individual can get their bone grafts covered, but the implants won't be covered, and they're on a state health insurance plan. This same process work for them, given they have state health insurance?
Is it like a government funded plan, or is it like you're a state employee?
Does not say. Let me see if I can find that information out.
Okay. If you're a state employee, you should be able to leverage if that's an actual benefit that you have. A lot of times it kind of is just asking the right question and talking to the right person. So I'm not saying that my job is always the happiest and I always talk to the rays of sunshine, but sometimes I call and talk to a really mean Judy, and then I hang up the phone and talk to a really nice Judy who says, actually, yes, this is totally covered. If it's a government funded plan, then I would have to do some research to give you an appropriate answer on that one.
Okay, and we have a couple questions that talk about government funded. So for those families that have submitted the question for Medicaid or government funded programs, if you could shoot me an email to kelley@nfed.org, we can get answers to you We just have to do a little research for your state. Another individual, their son's coverage was denied using codes D5280 and D5281, stating that it's age not appropriate. What does someone do in that respect?
If, so there are kind of a few trains of thoughts. One of them is the appropriate age to place, I'm assuming it's for implants, so I'm just going to roll with that. I'm assuming it's the appropriate age to place an implant. So there is a lot of research on the appropriate age to place an implant in something. And that would just kind of be, your provider would probably have to contact your insurance company and just go through that with them. If it's because they're saying that it's above the age limit in the plan, then that would take some further research. And if it is, there's sometimes like an age unit of like, you have to be 19 to get this treatment covered. You can then go and talk to whatever entity you got your insurance through, plead your case and say, hey, my son has ectodermal dysplasia. I know it has the 19-year-old clause on it, but he's 20 and we just got it diagnosed. Is there any way we can get this benefit put into the plan? And typically they will work with you.
Awesome. That's great information. So if someone's employer doesn't have, or the insurance is not providing the summary of benefits to someone, do they just go to their online account and find that information? How would someone access that?
So each insurance is a little bit different. Some do have really great online tools where you can actually pull up a summary of plan benefits. If you are not getting it through your employer, you can call your 800 number on the back of your card and see if they have that available. If they're not issuing it to you and just not giving it to you, I would just recommend continuing to harass them, because that's information that you have availability to and they really can't say no.
Got it. Can you explain the difference between the ICD-10 codes and the medical codes?
Yes, the diagnostic codes and the CPT codes.
I think that's what they're asking.
Yeah, so the diagnostic codes are, I think of it as in kind of like a hypothesis, as if then. So if you have atrophy, then you need something that stops your atrophy and corrects your atrophy. So if you have atrophy, you're probably going to need some bone grafting. So your CPT codes are going to come into play there. Once you have your bone grafting, you're going to want something that holds on to the bone graft. So you're going to want a bone stabilizer or an implant. So that's when your CPT code again would come into play.
Okay. So if someone has, where do they start? Should, and I'm trying to read into their question here, but do they start with their doctor as far as the diagnosis and gathering the medical codes? Should they start with their dentist or their prosthodontist? Who should they start with?
I do recommend starting with a doctor, like maybe a PCP or whoever diagnosed the patient at the beginning. Kind of just talk to them about what's going on. Sometimes your doctors are knowledgeable and they will say, hey, I actually know Jim Bob down the street and he's a dentist and he does this stuff all the time. Your doctors are a great resource and they can kind of help you gather the documentation that you're going to need to bring with you to your prosthodontist or dentist. Again, having all that documentation with you as you go forward is going to do nothing but help you. So I recommend having a doctor kind of sign off on the fact that you need this treatment, just so we can kind of be more cohesive in submitting it to your medical insurance.
Awesome. So if an insurance company approves partial charges, so not the full treatment, is there any recourse that a family has? Can they appeal those other charges?
It depends on why the other charges aren't approved. If it's just a contract exclusion, then you might kind of be out of luck on that one. But if it's something that's denied, maybe because documentation needs to be submitted, absolutely, you can do something about it. You can contact your dentist and say, hey, this documentation was never submitted. I'll help you. Let's get it submitted. Once we get it submitted, then, you know, that extra code is going to be approved. If you needed to do a prior authorization, You can call and ask if a retroactive prior authorization is an option. Typically there is an option. It just depends on why there's a partial denial.
Okay. I'm going to, let's see, we've got several questions, so everybody bear with us, okay, as we try to get through these and try to get all your questions answered. So a family has finally received approval for their daughter's denture through their health insurance after fighting for a year, only to have them not pay the bill due to an incorrect modifier code that was used by the provider.
Mm-hmm.
It's 25, code 25. She doesn't know what that means, but her provider has since stopped responding to her request to figure it out. So they ended up having to pay out of pocket due to the paperwork error. How can a family address this with their provider or figure out what needs to happen next once they get this notification?
I will say probably the way to get my attention most would just be to show up at the office and kind of just be like, hey, this is going on and I need to talk to this doctor. So let me know their schedule and I'll either pop in or just keep coming in every Tuesday at this time until something gets answered. Typically, and like I said, I work in an office where we do actually file the insurance, so I might be speaking from a bit of bias or naive thought, but typically this is something that if you bother them enough about, they're going to respond to you. And I know that that's not fun, or you shouldn't have to do that really, but sometimes it just takes learning the process and being able to execute it together. Getting involved in medical insurance is very daunting. I talked you through a very speedy version of what I do on a daily basis, and we are pretty streamlined in what we do, but starting out is just a terribly daunting phase. There's a lot of work, there's a lot of late nights and research, so maybe this is the first time your provider is doing that and they're just completely overwhelmed and are trying to get their bearings. But I would just say, keep contacting them and trying to understand it together, because you don't want them to do the same modifier on your next claim or on the next patient that walks in. It's very much a learning process together.
Okay. Have families been successful using ADA codes?
So if you use an ADA code, and I think I'm going to kind of answer two of these questions. An ADA code, if you lived in Arkansas and you had a fully funded plan and you had a congenital anomaly and you got approval for your treatment, you could use an ADA code then, only because we have an act in Arkansas that says that your dental coverage is part of your reconstructive procedures that need to be covered under your health insurance. So if you live in a state that has this legislation passed and you have the appropriate plan that lets you leverage this, then yes. If you do not have that, then I would say you're probably not going to be as successful using ADA codes for a medical claim.
Okay. Let's see. So you did talk about, and you briefly touched upon it here as well, the state legislation. Just so everybody knows, on the NFED website, if you can, in the search bar, you can search, I think it's Insurance 101, or you can go to the website, which is www.nfed.org, and go to treat, and under there you'll find the information for the insurance assistance program. We have links to all the state statutes, so you can find your state, click on that link, and you can see what the oh my goodness, the verbiage is. If for some reason the link is broken, just let me know and we'll get that fixed for you so that everyone can access it. But there is some information out on our website. Do you have any additional information, Sarah, to share about state legislation and what you already mentioned?
I would just recommend researching it as much as you can. Some stuff is out there and some stuff definitely needs to be out there. So just do your research on what you can do, because half of your problems maybe could be solved by just knowing where and how to leverage what's already out there, if that makes any sense. But kind of just educating yourself with what's out there and available might make it easier to leverage the stuff that we're trying to get covered.
For sure. All right. Can you go back to the medical form and share block 21 or explain what block 21 is on that medical form? And that,
So let me pull that back up really quick. Oh, it's your diagnostic codes. So there you're going to list your diagnostic codes that you're using for that claim. And then once you have your diagnostic codes in each box, I think it's A through L, then you'll pull those diagnostic codes down into your procedure codes. So diagnostic code AB is the reason that we got bone grafting. So you'll just pull down the letter that says AB, and it'll tie it all together.
perfect. Thank you. I hope that answers our question.
Yeah.
How can insurance companies be prevented from treating dental providers as out of network from the medical provider network, especially since there are no in-network medical providers that provide the needed dental care?
Yes.
That's a good question.
It is a good question. And if I'm being honest, we obviously we deal with this every day. We get denials just because they see that our doctors aren't MDs. The best way to do it is just keep bothering them and, kind of make a ruckus. They're not going to want any attention drawn to that insurance company. But if you just keep saying, this is just an issue, I need to speak to your supervisor, I need to speak to someone who can actually get something done. I have these benefits. I know I have these benefits. They should be covered regardless of who's performing them. That's pretty much the only way I've known how. We've been fortunate to have patients who are willing to talk to high ups in their insurance or high ups in their company. And that has helped us get through some insurance issues. It's mainly just about talking to whoever you can reach out to and just telling your story to whoever will listen. And then that sometimes gets you an inch further to getting stuff covered.
All right. Do you recommend submitting your provider to be added as an in-network provider before asking for gap coverage, as it only takes a few minutes to submit to your insurance provider?
No. Typically, I don't think patients can do that. But whenever we are looking at becoming an in-network provider, we look at their fee schedule. We look at pretty much everything they have to offer. If they have any codes that are kind of like our codes that we typically leverage. Again, not every insurance is the same. Not every insurance has the same fee schedule. It changes depending on state, region, whatever. So I definitely don't recommend doing that just because the provider might struggle a lot more if that's the case.
Okay. Let's see. Sarah, can you talk, your office files for all of your patients affected by ectodermal dysplasia, is that correct? Your patients are not filing themselves in all cases or most?
We file for all of our patients, yep.
Okay. I don't think we've answered this question, but I'll go ahead and ask it just in case. What if your specialist provider refused to submit CPT codes? For example, orthodontist submitted as only dental codes, even if you have a letter from the practitioner that states it is medically necessary?
That kind of depends on where you are. Like I said, if you have one of those states that lets a D code be filed, and you have that special plan that lets it be filed. Otherwise, there are CPT codes for pretty much everything that you can find. If it's just your provider's not submitting them in a CPT form, then I would just kind of recommend staying on your provider and saying, hey, these need to be submitted as CPT codes instead of CDT codes. A lot of it has to do with the way that the coding is automated on the insurance side. So if they're seeing a D code, it's automatically going to get thrown out because they're like, oh, it's filed to the wrong place. So definitely work with your provider and try to get them to use the appropriate CPT code because there are tons and tons of CPT codes.
Okay. Can you talk about the appeals process for everyone? I know it can be lengthy, and we have about 12 minutes left, but we do have several questions of, okay, we've been denied, now what? Can you talk about that next step?
Of course. So I think the biggest thing to identify is why you're still being denied. If it's one of those cases where you just don't have benefits in your plan for that, that's where I would recommend getting someone higher up involved, like someone at your company who's in charge of insurance. Say, hey, this is what's going on, plead your case, and see if that can help get pushed through. Also, your company has a contract with that insurance, so they kind of have a special relationship that says, no, actually this year we want to have that covered. So it can be as simple as talking to them and then working your insurance and getting that approved. If you're going through an actual appeal, we figure out why it's denied. Then I recommend just sitting in there. They can be kind of lengthy processes, but man, sometimes they go perfectly and sometimes they take a year. Each insurance is different, but they typically will talk you through the appropriate steps that you need to take. Sometimes there's like a first level appeal, or there's a peer-to-peer with your provider. Maybe it's a second level appeal, whatever it might be. Just follow the steps that they have, and typically once you exhaust all the means that are possible, hopefully you get to the outcome that you need and want. But I will say it's not the shortest process, and you're not necessarily doing anything wrong. I go through appeals, everyone goes through appeals, so definitely don't think you're alone on that. Just sit down and kind of ride the ride and see where it takes you. But I will say a lot of our appeals are kind of bypassed by getting the employers involved. Like I said, they have a special relationship with the insurance company that says what and when is covered. And if it can be just as simple as your manager emailing someone or calling someone at Cigna saying, hey, no, we're going to cover that this time, then that's honestly as simple as it can be sometimes.
So when someone does respond to their first appeal, let's say they're on their first appeal and they answer what's addressed in there, should they resubmit everything that was submitted the first time, or a copy of everything that was submitted the first time, or should they only address what's in the letter, send it off, and hopefully it should be good? Is it good to put that initial paperwork in front of their faces again?
Usually it's probably sent to the same people that are reviewing it, so you don't necessarily have to send the same information. Sometimes honestly, this week I had an ectodermal case that was going to be denied unless they gave them a specific measurement that they wanted. And all I had to do was send a specific measurement. I think it was like an overbite of a specific measurement or an open bite of something. And that's all I had to send. So basically, if they're asking for something specific and it's basically just sitting on that one specific piece of documentation, then I would say just contact that person and give them what they're wanting. If it feels like it's kind of 15 different people involved in one case, then there's no harm in sending a table of contents with numbered pages saying, here's exactly what you wanted, and just so you have this in front of you, here's all this additional documentation as well.
Okay. Do you recommend to all your patients, or I should say with all your patients, do you submit first to their medical insurance? Do you ever go the route of the dental insurance, or do you always submit to medical?
We have, we don't see only ectodermal dysplasia patients, so just patients that have like fillings or something, then we'll do dental, but we leverage their medical insurance if it's something that's going to be a full mouth reconstruction. It's just so much better for the patient to leverage the medical, whereas the dental doesn't have as much of a financial help to it as compared to the medical.
Do you think submitting to the dental first, if someone's going to self-submit, if they submit to the dental first, is that going to set a precedence of what they're trying to accomplish, and that's stating that the treatment is a medical necessity, that it's not a medical necessity? I mean, if they go the dental route first.
So this is kind of a new thing. A lot of dental plans, when they realize that you're submitting something that should be covered by your medical plan, they will kind of write you back with something that says, hey, this should be submitted to medical first. So if you're going to submit anything first, I would recommend the medical. And if it gets flat out denied on the medical, then submit to the dental.
Okay. What about orthodontic? Are families successful in getting orthodontic covered by their medical? It seems, you know, it seems like it's certainly a big part of the treatment for many families.
We work with one orthodontist in town, and as far as the treatment goes that route, typically yes. But I would say I don't have a ton of experience in the orthodontic phase to say confidently yes or no. But I know, especially the evaluations and part like that are kind of cost built into the treatment, those for sure can get covered. That's kind of just like an evaluation at your doctor's office when you go in for that. And that's just something that they could easily submit to help alleviate some of the costs for sure. If you wanted to know more about that, I could definitely look into that for sure.
I think that's helpful, but certainly we'll reach out to you.
Yeah, I've gotten that question a lot, and our patient base usually is, you know, well, I'd say like 15 up. So they've typically gone through the orthodontic phase once they get to us, or we find them as kids and we're like, hey, your next step is orthodontic phase. So we don't have a ton of patients that are in orthodontic phase currently, but yeah, that's definitely something that we do try to help them get covered on. And there are successes in that. I do know that.
Absolutely. Have you ever had to submit claims for any of the levels of TRICARE?
Yes.
Yes. Can you talk about what option was successful for you, if you can recall that? I realize you wouldn't have those patient notes in front of you, but
yeah. So we've had actually two types of TRICARE successes, and the first one was before it went to TRICARE East, so it might be old information, but I know that it has been approved. One was through like just active duty TRICARE, and then another one was they had additional dental benefits they had like an additional dental plan that had a crazy high maximum on it, and we actually went through their dental code. We used their dental codes on that one, but on the first one, the one that was just TRICARE for life, we used the CPT codes, did a standard prior authorization, got that approved, and we submitted paper claims and documentation. They were both quite smooth. They're a good company to work with for sure.
Okay. Let's see. If we look at the state statutes, can those help when you're working with a self-funded or a self-pay plan?
Speaking just from working in Arkansas, it's not dictated that way. But a lot of places, once that legislation is passed, a lot of insurances or companies that have insurance will kind of adopt what the norm is. So I have a lot of self-funded plans that have the little blurb of if it's for a congenital defect, they have to get everything approved by a craniofacial board, and you know, it's the same, like you have to pre-authorization everything, but it's still a self-funded plan. So some of them kind of act in the same regard, but it's not necessarily as beneficial as having a fully funded plan, because when a fully funded plan goes against the act that we're leveraging, that we're successfully leveraging, then there are actual consequences on that insurance if they deny it, or if they, you know, try to act in a certain way that's not in the manner that needs to be upheld.
Okay. Are HMOs harder to work with than PPOs?
I have not noticed that. With your HMO plan, you're just going to need a referral from your PCP to see any sort of specialist. So if you're going to a dental professional, just have them send a referral with you.
Okay. Let's see. Why won't dental providers bill for dental as medical care the same way medical providers bill?
That's,
I don't know that we can answer that.
that is $1 million question, and I think
That's right.
that's one that just needs to keep being asked. A lot of right now what's happening is people are finally thinking as your whole body is your whole body. Your whole healthcare involves your mouth. So definitely asking that question. It is down to simply dentists just aren't given the information on medical insurance as they are on dental insurance. I know that dental insurance is something that is a slam dunk for dentists. Obviously, it's in the name. So it's honestly just more educating and more pushing for standard level of how to think of your care. So it'll be a question that we'll ask for a few more years, I guarantee it, but keep asking it.
Yeah, absolutely. Well, guys, I know there's a lot of questions that we didn't get to, but please, I did type my email address in the chat function, but once again, it's kelley@nfed.org, or you can find me on our website. But I want to thank everybody for joining us tonight for our first webinar of the year. And Sarah, thank you so much, not just for giving us your time tonight, but we certainly appreciate your expertise and just the dedication to families that are affected by ectodermal dysplasia. And thank you for always helping me personally when our families reach out to our office. I know you have a ton of questions for me, and certainly we learn as we go. So we're really grateful to you and Ozark Prosthodontics. So thank you.
Thank you.
And all of you out there, I'm listening and that tuned in tonight and maybe even listening on the recording, I know you're working so hard to have your medical insurance cover your dental claims. Keep working on it. Don't give up. If you need resources, there's lots of resources on our website, as we mentioned earlier. You can always call or email me at the office. But also, in addition to working hard and getting your coverage, you know, if you would really begin to advocate for the Ensuring Lasting Smiles Act, contact your legislators. All this information too is at our website. Ask them to support the Ensuring Lasting Smiles Act. If we get this federal legislation passed, it's going to save everyone a lot of time and headache and heartache. So check all of this information out on our website. You can see the list of upcoming webinars on our website as well. And we're always here at the office. Well, tonight I'm at home, but we're always available at the office and by email. So please never hesitate to reach out and contact us for help. That's what we're here for. So thank you, everybody. Have a wonderful evening. Enjoy what's left of it. And let's see, have an awesome Valentine's Day later this week. Good night, everyone.